first question that I see is, what are your thoughts on the use of an ALK TKI post-chemoradiation for stage 3B lung cancer? This is a very good question, and one that us oncologists struggle with a lot and discuss all the time at these conferences. So right now, the standard of care for patients who receive chemoradiation for non-small cell lung cancer, as many of you know, is immunotherapy with durvalumab based on the Pacific trial that demonstrated survival benefit with durvalumab after chemoradiation. Now, that trial did not exclude patients who had EGFR mutant or ALK positive lung cancer. So technically, it would still be considered standard treatment. However, we know, extrapolating from our experience in stage 4 lung cancer, the efficacy of these checkpoint inhibitors, similar to durvalumab, are very limited for patients with ALK positive lung cancer. And so our enthusiasm for using durvalumab in stage 3B after chemoradiation is tempered, and we always make sure to discuss the potential benefits and risks. The potential risk being that if you do receive durvalumab and then have disease recurrence, then subsequent therapy with an ALK inhibitor, there could be potential augmented toxicity from a sequential immunotherapy and then TKI exposure. That gets me to the point of, well, what about using an ALK inhibitor after chemoradiation? And that is not currently standard of care. But I think it is something that we always discuss with our patients. Many of you know about the ADAURA trial that looked at surgically resected EGFR mutant lung cancer patients who received adjuvant EGFR TKI, and that data was very positive. There's an ongoing trial in ALK positive lung cancer looking at alectinib in the adjuvant setting in surgically resected patients. Of course, that is not for patients who receive chemoradiation. It will have to be answered with rigorously designed trials looking at the efficacy of ALK inhibitors post-chemoradiation. But I think it is something that we always think about and discuss with our patients, even though it's not standard of care.
Yeah, I agree, because it's hard to recommend something that is not proven. It's very tempting. Because we know that these ALK inhibitors are great. And if the patient has finished chemoradiation successfully, we get these questions very often. That's why also in stage 3 is like not standard of care to do testing of genetic aberrations, you know. That is why when you test in a patient in stage 3 that's supposed to get chemoradiation and durvalumab, then you end in a problem, because if it's ALK positive or EGFR positive, you have the temptation to say, maybe instead of the durvalumab, I'll give osimertinib or one of these ALK inhibitors. But as Dr. Lin said, it's not standard of care. It's very hard to recommend something. It may work, it may not work. We don't know.